was done, completely done. There I was at the edge of my own existence, completely unknown of everything that was going on, recovering from orthognathic surgery. My journey to healing, which I thought would be a part of a symphony of care and confidence, was a solo act in a vast of pain and frustration. And the swelling, the swelling, it clung to me like a parasite, destroying not just my face, but my spirit. Every look in the mirror was like a monster staring back at me. I didn't know who I was anymore. My journey as a dental hygienist at this point took a really consistent shift. The things that I was doing in my care as a dental hygienist, what was I missing in my patients? If I went through this journey, and mine was an elective journey, what about my patients in non-elective journeys, in non-surgical or surgical rehabilitative care? So with this insight, I took up the baton. And there I was, going to conduct my own symphony to bring a collaborative care of harmony to life for my patients. And the results? Christina, 10-year oral cancer survivor. She came to me with unrelenting pain in her arm. She couldn't move her arm at all. She had months of speech and language pathology, speech therapy, just so she could sing again. And it was unrelentless. She couldn't get anywhere. Well, I wonder why. Her tongue was handcuffed to the floor of her mouth. Speech therapy wouldn't have helped this because she has no function, no range of motion. So it took me 8 sessions over 2 months, releasing that scar tissue, and she was able to sing again. And then there's Jennifer, oral cancer survivor, 4 years. She struggled to get through her dental cleanings of the pain. Her daughter's a hygienist who had to get her numb at every single appointment because the tissue in her mouth was so hypertrophic from the radiation therapy. All she wanted to do was help. This is one 45-minute session, releasing the scar tissue in her mouth. My experience with these cases gave me a glaring oversight in dental hygiene education, where we're so narrowly focused on the teeth, we're not looking at the optimal function of oral health. So what can we do? When I was talking to medical providers about what they do in post-surgical rehabilitative care, they already think that dentistry is doing it. But when I talk to dentists, they're like, well, medicine's doing it. Speech and language pathology and your manual therapists. And so, but what happens is that there's a miscollaboration. Nobody's going into the mouth. Physical therapists don't know the orofacial complex. There's only 7 states where massage therapists do intraoral massage, but they don't know anything about the plaque biofilm and how to reduce the biofilm and bring recovery and orofacial function. They don't know any of the 8 muscles in the tongue and how they move. And around and around and around it goes. So what do we need to do? Dental hygienists, we are in a position, we need a massive overhaul in our workforce, and that's where it's going. By 2040, they expect hygienists to be more in hospitals than in palliative care. There's not a lot. We have our hygienists in our hospitals that are doing pre-surgical work for oral cancer to make sure everything is good. But what about the post-operative care? Dentists, imagine this. You have a patient in your chair. They are diagnosed with squamous cell carcinoma. You send them off for surgery, and what happens then? Where do they go? How long does it take for them to come back into your chair? So the question is that you can have your hygienist, or the solution, you can have your hygienist who's builds up that rapport with that patient. That hygienist is there from diagnosis, following them through into their surgery, and into their rehabilitative care, and then coming right back into your office. Your hygienist should be doing the lymphatic drainage intraorally, the PAC biofilm, helping reduce risks for decay, preventing further destruction of the periodontium, but it also helps retain that patient in your practice. So hygienists need to look beyond myofunctional therapy and airway and growth guidance and add in manual therapy techniques, as well as have the opportunity to add in oncology aesthetics, because it's not just about teeth and gums. Mental health is a pretty big deal when it comes to people who have these major constructions. So they're already doing it in Japan. Japan is in the hospital as a hygienist. They're doing the palliative care. They're doing the rehabilitation. They're doing the orofacial myofunctional therapy. And it's decreasing patient care and quality. It's decreasing patient hospital stays and increasing quality of life. So hygienists, we've already expanded our practice to the point where we're doing laser therapy, myofunctional therapy, and perioscopy. We need to expand beyond that. So dental needs and palliative care problems in dental hygiene education, this is what we need to be doing to advance and care more for these patients in these situations. They're being completely ignored and dropped off. We need to look beyond traditional dentistry into rehabilitative and acute care to help increase quality of life for our patients. This allows us to create a bond with our patients for more long-term sustainable results. For example, Tiffany, let's go back to non-surgical. She had root canals in all of her teeth. She saw me for 7 sessions. We reduced some trigger points, and we were able to get rid of the pain. 5 years she was struggling with tooth pain. Trigger point therapy. And then what about Michael? 14-year oral cancer survivor. He came and saw me with a lot of encouragement to get his tongue moving again. 14 years. The only person that he saw was a dietitian. They moved a portion of his bone from his leg and put it into his lower jaw. And he only saw a dietitian? He didn't see physical therapy? He didn't see anybody. So he came to me after 8 sessions. I forgot my water bottle. What do you mean? I forgot it. I was sitting at church, and it's been strapped to me for 14 years. And I forgot it in the car, and I didn't even think about it. My saliva's coming back because we were massaging the parotid gland, trying to get things working again. So forgetting his water bottle was a big significant insight, and it bears more research. But with his water bottle and missing that, in only 7 sessions, if we do the math, he's seen his hygienist for 14 years. He saw his hygienist 4 times a year. That's 56 missed opportunities that dental hygienists had that they didn't take because they didn't know that we could do these things. So this shows us a lot of hope for more patients and what we can do in post-acute and palliative rehabilitative care. So we need to bring up the cellos and drums and a good chorus and under a conductor. We need the trumpets of dentistry and the pianos of medicine to come together in collaborative care for more opportune function for these patients so we can bring the music and symphony of patient care to life.
Great job, Rebecca. The work you're doing is heroic. You're not going to leave me yet. You get to stay up here.
I'm done.
That's right. She's out. No, that was great. And this is heroic work. And you're changing people's lives. I told you guys, we're changing the world all the way across. It's amazing. So tell us a little bit about how you bring this work into practices. What are your presentations look like? Are they workshops, lectures?
So I've just connected with the National Network of Healthcare Hygienists, and I've got the Orofacial Recovery Institute, and I'm doing a crash course on June 17th. but I start with the basics, just TMJ, massage, and just doing intraoral manipulation as hygienists and dentists. But I also teach the intraoral lymphatic drainage and acute care component. And I tie a little bit of that in with the craniosacral rhythm, and of course, somatic emotional release, because there are issues in the tissues. And if you've ever had a massage,
that's a T-shirt, by the way. Issues in the tissues.
So I realized that there was a gross oversight in dentistry and dental hygiene care when it comes to acute and orificial rehabilitation. Massage therapists, they go into the mouth and they're not trained what it is that we can look at the biofilm and anatomy and physiology and dental terminology. So I'm trying to train massage therapists more in the dental aspect, but even physical therapists, they're not trained in the head, the neck, and the mouth. So it's a very glaring oversight. And a great opportunity for dentistry to really take this up and move it into palliative and acute care. So we just stop forgetting these patients and they keep them coming back for optimal oral health.
I love it. I love how you've brought the two modalities together. Brilliant work. Thank you.
Thank
Great
you.
job.